Good afternoon, everyone. My name is Doreen. I'm with the New England QIN-QIO, and I will be moderating today's webinar. Thank you for joining today's webinar, Stewardship Collaborative Kickoff. I have muted all the lines. Speakers, please press pound 6 to unmute your line and wait 10 to 15 seconds. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. The presentation is available on the event webpage. We have or will post the link in chat in case you haven't yet downloaded it. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines are on mute for the duration of the presentation. We'll take questions in chat at the end of the presentation if time allows. At this time, I will pass things over to Carol D. to get us started. Thank you.
Good afternoon, everyone. Welcome to the New England QIN-QIO Kickoff webinar series for the Outpatient Antibiotic Stewardship Collaborative. We are so excited to start this kickoff. As Doreen mentioned, I am Carol Dietz, one of the Connecticut Antibiotic Stewardship team members, and I am here along with Margaret Crowley, who is from the New Hampshire Antibiotic Stewardship team, bringing you this first webinar for the New England region. I will be introducing the other state leads along with their contact information at the end of our session. But please know, we are just an email or a phone call away for our recruited entities and our partners to make sure that this collaborative goes smoothly. We have a jam-packed half hour, so I'm going to get started. Again, welcome. We can't thank you enough for spending some time with us today. The Outpatient Antibiotic Stewardship Collaborative is all about reducing inappropriate use and misuse of antibiotics at the bedside. This webinar will be recorded and available on our website, so please download it and use it for one of your staff meetings. Again, this is all about level setting, about what the work is, about what we're all about. If you do have any questions, as Doreen said, please put it into chat, and we will be answering the questions at the end if we do have time. But we know how quickly a half hour goes. The objectives for the day, for the next 30 minutes, is to describe at least 3 ramifications of inappropriate use of antibiotics in the outpatient setting, describe the CDC's 4 core elements of antibiotic stewardship in the outpatient setting, and then define the support that is available for each of you, each of the recruited entities from the New England QIN-QIO. Before we get started on our journey, I just want to level set everyone. For those of you who have never worked with a quality improvement organization, as we'd like to call us now, it's the QIN-QIO, which is the Quality Innovative Network Quality Improvement Organization. The New England QIN-QIO is made up of 2 partners. Health-Centric Advisors is our lead, along with Qualidigm, and we're working together to work on this very important initiative, and we cover the 6 states of New England: Maine, New Hampshire, Vermont, Massachusetts, Rhode Island, and Connecticut. And we're focusing on quality improvement activity wherever the Medicare beneficiary touches. So we have experts in all 6 states that work in hospitals, nursing homes, home health agencies, physician offices, FQHCs, retail pharmacies, ambulatory surgeries, surgery centers, again, wherever the Medicare beneficiary touches. The 4 key roles of a QIN-QIO are, first is to facilitate learning and action networks. We create an all-teach, all-learn environment, placing motivation for improvement at the bedside. We also teach and advise as technical experts. This technical assistance is available for all our recruited entities until July 2019. We also work with a champion at the local level, creating results-oriented change. We are here to help you get access to your data so you can then use it in your quality improvement work. And we're also here to help you engage with your patients and other stakeholders to make sure that they understand the work that you are working on. And finally, we are here to help spread the innovation throughout your entity, throughout your site, and so that it will become part of your culture. So let's talk about the outpatient setting. Many of you are saying, well, who else is working on this? While I'm running through this list, if you could put your name, where you work, and what your role is at your site. So whether you're a physician, an office manager, the practice manager, a registered nurse, a CNA, just let us know what is your role in your office practice, and make sure you send it to all participants so we all can see who's listening in today. So outpatient settings, who's participating in this important work? We have recruited emergency departments, primary care clinics, urgent care centers, federally qualified health centers, physician offices, and outpatient pharmacies. If the list is long, but again, this is so important that we want to make sure everyone is involved. And thank you for putting your names in. Thank you. Keep it going. So the goal of CMS, for those of you who don't know CMS, it's the Centers for Medicare and Medicaid Services, and the CDC, which is the Center for Disease Control, is to reduce unnecessary antibiotic use and misuse in all settings. Through multiple studies, it has been found that antibiotics are responsible for almost 1 out of 5 emergency department visits for adverse drug events. 1 out of 5. Antibiotics are the most common cause of drug-related emergency department visits for children. And it also has been estimated over 2 million illnesses and 23,000 deaths occur each year due to antibiotic-resistant infections. The CDC has found that 30% of all antibiotic prescriptions in the outpatient settings are unnecessary, which equates to 47 million unnecessary antibiotics per year. The goal, written by President Obama in 2015, is to reduce inappropriate outpatient antibiotic use by 50% by 2020. So we have a lot of work to do in the next 3 years. With that, I'm going to turn the presentation over to Margaret.
Thanks, Carol. Next slide, please. So Carol has pointed out a number of reasons why we should care about judicious antibiotic use. I want to give you an example of what the emergence of antibiotic resistance looks like with this cartoon. Carol mentioned a few of the reasons earlier in terms of the number of visits to the emergency room with symptoms related to antibiotic treatment, things like allergic reactions, for example, to antibiotics, or drug interactions, Coumadin potentiation, for example, with some antibiotics. But the prime reason is that simply using antibiotics contributes to the emergence of antibiotic resistance. This cartoon provides a useful illustration of how antibiotic resistance happens. The key point is that resistance emerges as a normal consequence of evolution by a process that you probably heard about the first time in middle school, the process of natural selection. So take a look at step 1 in the diagram, and this depicts the normal state of most what I would describe as non-sterile human tissue. There are lots of bacteria present, lots of different types. We've selected an antibiotic, let's say, to treat an infection that involves one type of bacteria. The antibiotic won't just slow down or kill the pathogen we've targeted, unfortunately. It will kill lots of the normal bacteria present as well. Through the process of natural selection, some of these bacteria may be resistant to the antibiotic, or they may be intrinsically resistant. When we kill off the bacteria that are susceptible, the resistant ones are given the advantage of having space and food to multiply. In some instances, these bacteria may even have more complicated mechanisms of resistance that allow them to share a resistance gene with another type of bacteria. They can pass on their resistance trait to their offspring. Resistant bacteria then have what's called a selective advantage. And I think a good example to think about here might be the selective advantage that Clostridium difficile has in the presence of antibiotic treatment that has killed off other bacteria and given C. diff an advantage. I do want to point out here, too, an analogy that's pretty important. In a paper, the Institute of Medicine noted that antibiotic resistance is analogous to climate change and the global water crisis. These three consequences have all been catalyzed by what we think of as rational behavior, that is, humans acting without restraint to maximize personal short-term gain. I want to also point out that the notion of stewardship, when we think of stewardship, is fraught with meaning, and it includes, for example, the words management or control. I also like to think of it as taking care or obligation, as well as safeguarding and preserving for future generations. The notion that making certain that antibiotics will still be here for our children and our children's children. Next slide, Carol. So the monitoring of outpatient antibiotic prescribing data is regularly conducted to analyze national and state antibiotic prescribing data in order to better understand trends in outpatient antibiotic prescribing, to identify where interventions to improve prescribing are most needed, and to measure progress. By measuring prescribing and appropriateness, we can compare performance across regions, states, and other entities. National goals are important to help drive change. Quality measures for outpatient prescribing can be used by clinicians, healthcare systems, health plans to determine if antibiotic prescribing patterns meet appropriateness standards. I'm going to be talking more about using various quality measures when I talk about this particular collaborative and aligning it with your quality payment program objectives. These data that we've presented here help describe how antibiotics are currently being prescribed in outpatient settings in the U.S. and how these practices are contributing to the larger issue of antibiotic resistance. We wanted you to see the variation in each of our New England states and the comparison with data across the U.S. And just as a reminder, Carol mentioned this, in 2014, 266.1 million courses of antibiotics were dispensed in the U.S. community pharmacies. This equates to more than 5 prescriptions written each year for every 6 people in the U.S. At least 30% were unnecessary, meaning that no antibiotic was needed at all. And the total inappropriate use, which is inclusive of unnecessary use and inappropriate selection, dosing, and duration, may approach 50% of all outpatient antibiotics. Next slide, please. So this slide depicts our game plan to work on this preservation effort in the outpatient arena. This is our framework for stewardship action in outpatient settings that routinely provide antibiotic treatment. So what we have here then, by way of core elements, is first to demonstrate a commitment or a dedication to an accountability for optimizing antibiotic prescribing and patient safety, action for policy and practice, tracking and reporting, and finally, education and expertise. By way of background, the creation of these core elements stems from a rigorous process of putting together a program with a research base to support the choice that you will make at your local level for interventions. The CDC works by compiling a series of 5 extensive literature reviews on antibiotic prescribing, as well as pulling together subject matter experts who then assembled this work and created an intervention plan for outpatient settings. Some of the work also consolidates steps from prior core elements documents that were created first off in 2014 and 15 for hospitals and long-term care facilities. So we were able to take that work and then use it going forward. Our plan, Carol, the next slide, is to do a baseline assessment. I realize that you may find this one a little difficult to read, but we're going to also make sure that you, if you haven't already seen this, we'll be producing a core element baseline report. So people at each practice site are actually conducting baseline assessments using this tool. Many of you may have found, for example, as you did this checklist, that you've already deployed some elements of the program over the years. We want to help you move forward so that you're creating an integrated program by selecting strategies from across the field of possible interventions. Having a smorgasbord, so to speak, of interventions, rather than perhaps just one, for example, hanging up commitment posters, has been shown to cause synergistic effects on the outcome. For example, putting forward 2 interventions or 3 is often more powerful than just taking one plus one and what that would seem to indicate. Next slide. Excuse me. This slide depicts. Carol, if you can go back a second, I wanted to also say something more about the slide. So this slide depicts the interventions that have evidence behind them for each element. It's sort of like a menu of options that practices can select from to intervene in ways that can lead to both improvement and also align with the culture of your practice, what's going to fit with your particular practice site. Remember, we're looking to both measure antibiotic prescribing and to improve prescribing by clinicians, as well as use by patients, so that they are only prescribed when needed. We're also looking to minimize the misdiagnosis or delayed diagnosis leading to underuse of antibiotics. For example, we'll look at opportunities that you might have to deploy diagnostic testing at the diagnosis phase to increase diagnosis certainty. So we'll be able to engage with you on some of those new tools. And finally, we'll focus on ensuring that the right drug, dose, and duration are selected when an antibiotic is needed. Thanks, Joe. Next slide. Next, I'll move into talking about some of the resources that we're going to bring to bear on this collaboration. This slide depicts a roadmap or a plan for implementing an antibiotic stewardship program. One of the resources or tools that our team has developed is an actual plan to use to map out your strategy going forward. This would be a great tool, for example, to create in your office and then publish it or make it available to all staff to see what you're working on as a group and where you're headed. This can help to unify the messaging, the focus, and the direction of all team members. Remember that in Alice in Wonderland, and I'm going to paraphrase this, the Cheshire Cat said to Alice, if you don't know where you're going, any road will do. So selecting the road that you're going to take will help you focus your endeavor. The other thing that I would suggest is when you meet with your practice consultant or your advisor, you can ask them to share this roadmap with you. Next slide. This is an example of another resource that we'll be able to bring to bear. This slide is an example of a commitment poster. We have different versions of the poster and can share these with you. We'll spend time with you selecting what you want and need specific for your practice, and we'll make these available to you that you can hang them in your office, in your exam rooms. These are important in sending an important message to your patients about your commitment to the antibiotic stewardship work. Notice that on this particular poster, it has been customized with the name of the practice group, and we can do this for you as well. We also have posters, just as a reminder, available in Spanish. In addition, we're anticipating quite soon that the CDC will produce an update of their Get Smart program materials And once this happens, we'll share these with you as well. Next slide. These are some examples of resources to use with patient education. We have on our website these types of materials, and Carol will be shortly introducing you to the website, but it's basically our www.healthcarefornewengland.org. One big stream. This is, again, on the next slide, if you will, is another example of educational materials targeted towards patients to remind them of the difference between, for example, bacteria and virus. These can be used as posters and can be enlarged to include the commitment statement as well. Next slide. We also have treatment guidelines to share for common infectious diseases and treatments that you may see in your practice. In addition, we can help you find and access updated guidelines for infections. As an example, on the next slide, the Connecticut team provided for one of their healthcare systems that were looking specifically for evidence-based guidelines regarding the treatment of sinusitis. They wanted something that was user-friendly and could be laminated for easy use in the physician office. And used perhaps as a visual discussion tool with the patient present. This could be a wonderful tool to use to share visually with patients. Next slide. Finally, I wanted to note that we can help you to locate the scientific literature that is linked to the interventions that you are considering deploying. We have larger literature reviews as well as studies focused on specific interventions linked to the core elements. For example, what is known about the effectiveness of giving individual feedback to providers regarding their prescribing patterns? That's just one example of the types of studies that we can share with you. I also would note that for those of you who actually have been on website that has the core elements, there's an appendix that can be used that directly links you to the research. So the URLs are there, and you can click right into the research findings that are sorted based on the type of intervention. But we'll help you get there. So I'm going to turn it back to Carol.
Thank you, Margaret. So, continuing on with what else is available for you, starting in October, we will be sending out a newsletter focused on antibiotic stewardship in the outpatient settings for our recruited facilities as well as for our partners and stakeholders. The highlights that we're going to be focusing on for the initial one will be how to succeed with the collaboration, as well as we're going to have an area for upcoming events on topics that may be of interest to you and your staff. We're also going to have an area on any national news related to antibiotic stewardship. We also are going to have a spot on promising practices that are being touted as innovative best practices that could change the way that we do certain testing. So again, it's sort of like a heads up of what's coming down the pike. And finally, we will highlight any new resources that have been added to our website, and also spotlighting a success story of a recruited entity or recruited site. So we will be reaching out to each of our sites to ask for a success story so we can highlight you in our quarterly newsletter. So as Margaret mentioned, I'm going to just briefly go over our website. So it's www.healthcarefornewengland.org. And Healthcare for New England is just one word. So once you get on our landing page, you're going to see the headings of home, get local for providers. Right in the middle of the page is initiatives. You're going to hover your mouse over that, and a drop-down column will appear. And you're going to go down almost to the middle of the drop-down to where it says medication safety. And the way I remember where antibiotic stewardship is located, antibiotics or medications. And so this is all about keeping our patients and ourselves safe. So medication safety, you're going to hover over there, another little drop down is going to appear, and you're going to click on antibiotic stewardship, just like it's shown on the slide. So once you get on the antibiotic stewardship landing page, you're going to have 3 buttons to choose from. One is a webinar and phone calls, and this is where all our webinars related to antibiotic stewardship and the outpatient setting are going to be located. Not only are you going to have the slides, but you'll have the recordings and any questions and answers that we weren't able to answer on the call will also be located there. The second button is the resource button, and this is where we're going to be refreshing. Every quarter, we're going to be adding new resources, whether it's from the CDC or Choosing Wisely. And in this area, once you get on the landing page, you're going to see it's broken down. The resources are broken down into 5 different groups. The first one is a general resource area for antibiotic resistance and stewardship. Another area is going to be print resources, and these are going to be the resources that you can just download immediately, that we fixed it so you can just print it and it's going to be user-ready to go if you would like to print from our website. Another group is resources for everyone, so not only for clinicians but also for patients and families, all about antibiotic stewardship. So it's from the CDC, it's from Choosing Wisely, and again, we're going to be refreshing this area each quarter. And finally, there's a resource for providers, and these are for the clinicians. These are the documents that are best practices for clinicians. An example of one that's there right now is an evidence-based best practice. That's a document for warfarin and antibiotic interactions from Pharmerica. So that's a very important document that you could download, laminate it, and give it to your physician so they can, it's an easy resource, it's a very important resource reference for your physicians to have. And finally, the 5th grouping is Spanish documents that are already translated into Spanish, so you can, again, download from there. And the 3rd button on that landing page is where our contact information is for each of our state leads that are part of the New England QIN-QIO.
Okay, thank
Margaret,
you.
back to you. Yep.
Yes, thank you. I did want to point out, for those of you, not all practices are going to be affected by this, but the quality payment program, some of you may know is the MIPS and MACRA programs, for example. You may be able to link your activities in the Antibiotic Stewardship Collaborative and get a little more bang for your buck here, so to speak. The MIPS program, for example, you earn a payment adjustment based on evidence-based and practice-specific quality data. You show you provided high-quality, efficient care supported by technology by sending in information in the following categories, which are quality, improvement activities, and advancing care information. Those of you who are involved probably know this. Cost as a measure is going to not kick in until next year. Just wanted to point out that in terms of selecting quality measures, you could actually have the opportunity of selecting quality measures that you're using for this program, such as the treatment of adult sinusitis, for example, and the overuse of antibiotics. Another quality measure might be on appropriate treatment of URI in children. That's one to select from. And surgical site infections have just been added recently. Under improvement activities, you can earn points as well, simply by implementing an antibiotic stewardship program. So you have 2 categories in which you can earn points based on your participation in our collaborative. Next slide, please. And finally, I wanted to point out that we can, in fact, make visits and perform consultation visits with your practice. And just some of the examples of the activities that we might engage in are to help you, for example, set up your roadmap with your team. Remember that we're going to be engaged with you, as Carol pointed out earlier, until July of 2019. We can help your team to select interventions and strategies, to work on data collection methodologies, for example. As one example, I can tell you that I'm working with a group of practices who have chosen to focus on appropriate treatment of uncomplicated bronchitis. Because they have a new EHR, they're struggling with getting data right now, so we're going to help them to use an audit tool with our support to collect some baseline data. And we'll also work with people, for example, to focus on workflow and how to maximize the flow of information through the various people in your department so that everybody is sending a unified message to the patient, for example, from the front desk, making appointments to the checkout process. So, again, next slide. I also want to point out that one of the QIO-associated activities with this program is to work with other stakeholders in the development of a statewide multidisciplinary advisory group or team that's focused on antibiotic stewardship. So there's one in all 6 states. Many of us have linked up with programs that were in place to add a layer that focuses on antibiotic stewardship. For example, in New Hampshire, we have teamed up with our statewide ARAW, which is the Antibiotic Resistance Advisory Work Group, which is a team that is addressing drug resistance via the New Hampshire Public Health Department, and we're including antibiotic stewardship, rightly so, in this group. We have approximately 35 members in the team, and it's drawn from all clinical practice sites, including not just the outpatient setting, but the inpatient, nursing facilities, and even dental offices. In addition, in New Hampshire, we've approached our team from a One Health perspective, which actually takes an integrated approach, linking human health with animal health and environmental health. And the notion that these are all inextricably connected to one another. We'll be sharing, so in this group, not only do we have clinical folks, but we also have representatives from the veterinarian community as well as the feed animal community. We'll be sharing information with you about activities at the state level through both our newsletter as well as in our regular contacts with you. And finally, Carol.
Yes, thank you, Margaret. So let's talk about some key tips on how to be successful. Each site needs to know your antibiotic stewardship task lead, or like we like to call them, the champion. There should be one in each office. And also, if you're working within a big healthcare system, there needs to be a champion at the corporate or the leadership level. And also, you need to know your state New England QIN-QIO task lead. So all 3 of these leads, all 3 of these champions, we're champion here at the New England QIN-QIO. We all need to be working together to make sure that you're implementing the best fit antibiotic stewardship program for your site. You have to keep talking to your staff. This is not a one and done. Please use this webinar as an intro to this important work. Please use the newsletter that when it comes out in October, make sure it gets out to your staff members and keep talking it up to make sure it doesn't lose momentum. Also engage your patients. Every time you're talking to your patients about their medications, just sort of go over to the commitment poster that's going to be located in your treatment room and talk about how antibiotics now have to be really scrutinized before you give them out, and why it's so important. And then make a plan. You just can't throw out these interventions and say, okay, here's our antibiotic stewardship program. You've got to make a plan, working with your New England QIN-QIO state lead and your champions, and then start one intervention. Start small. One office, one treatment room, one patient to see how the intervention works, and then start spreading it as you continue to monitor its effectiveness. And then continue on that way. It's all coordinated. This collaborative is very important, and it's part of a bigger coordinated response that touches everywhere the patient touches. With that, I'd like to leave you with the contact information for each of the 6 states. Francis Kissy is the regional New England QIN-QIO regional task lead, but he is located here in Connecticut along with me, Carol D. And my contact information was in the beginning. Massachusetts, Alyssa Dacuna. Maine is Danielle Hersey and Dawn Hobel. And New Hampshire, it's Margaret Crowley. Rhode Island, Maureen Marcella. And Vermont, Regina Ann Cooper. And so, again, as I mentioned earlier, we are just a phone call or an email away if you need any help or guidance. And we will be reaching out to each and every one of you to make sure that this work is continuing. With that, we are 5 minutes over. We apologize, but thank you so much for your time. And again, we'll be getting once Doreen, you're going to take us and lead us out of here.
Thank you all for a great discussion. I have just a few last announcements before we end today's call. When you close out of this webinar, the evaluation will pop up on your computer. If you could take the time to fill that out, we would appreciate it. If you don't have time to fill the evaluation out today or right now, or you are currently sharing a computer with someone else, you'll receive an email tomorrow containing a link to that evaluation. As we mentioned at the beginning of the webinar, the PowerPoint presentation is currently on our website. And within the next few business days, a recording and transcript will also be added. The link for this will also be included in tomorrow's email. Thank you again for this great presentation, and to everyone for attending. Have a great, wonderful rest of your day.
Bye, everyone. Thank you. Have a great day.